Okay, thank you very much for giving the opportunity to have this interactive discussion about some of our cases. There will be cases that are not scleroderma because scleroderma was extensively discussed. And I will start with a patient that I've seen in 2016. She was at the time 38 years old. She was a saleswoman and she was a lifelong non-smoker and she doesn't consume alcohol at all. She had no obvious domestic exposure and she has a sedentary lifestyle. Regarding her background, she was known with autoimmune thyroiditis and also gastroesophageal reflux disease, and this was quite important, and she also had a reflux laryngitis. She was diagnosed with bronchial asthma, but actually we haven't seen, and because she was from another part of the country, we haven't seen any documentation for this bronchial asthma. And she has some extrasystolic arrhythmia. The only medication that she took, metoprolol or Meran, she was not treated with bronchial asthma, even she was prescribed before bronchodilators, inhalers with bronchodilators. So when I saw her for the first time in the day hospital in 2016, she presented actually for a rheumatological problem because she has a clear symmetric polyarthritis in the hands, and it looks exactly like onset of rheumatoid arthritis clinically, and I think it was confirmed serologically because she has a mild, moderate inflammatory syndrome, and she has a very specific rheumatoid factor in a very high titer, more than 400 units per milliliter, and anti-CCP was also high at the beginning of the disease. Regarding her X-ray, nothing specific because she has no erosion. She had this history of just 3 months of this arthritis. What we draw the attention to us when we did the physical examination, we heard some crackles at the lung basin, typically the Velcro type crackles. And anyway, we do an X-ray of lung always when we diagnose CTD as a screening method to see if there are some problems in the lung and to see what to do with medication. And if you look at the X-ray, there are some modification even from the beginning. There is a reticulonodular pattern described and also probably a tendency to have consolidation. Anyway, the radiologist interpret as a possible infection. Later on, we referred her to spirometry, functional pulmonary tests, and you can see that already it is a moderate restrictive pattern because the FVC and also the DLCA was reduced. It was 57 and the DLCA was 54. Regarding the 6 minutes walking test, her distance was quite reduced considering her age, and the saturation was normal before test, but after test she clearly desaturated quite significant because it was just 88%. So in this point, we consider this rheumatoid arthritis, it was very likely, not erosive, but still we have a lot of arguments that this is rheumatoid arthritis. And we thought about rheumatoid arthritis ILD, considering the fact that she has these crackles at the basis of the lung and she has abnormalities of the lung at X-ray at this moment, and we have the spirometry with a clear restrictive pattern. Of course, it was unusual the fact that we have just 3 months of evolution of this rheumatoid arthritis, but we know that at least rheumatoid arthritis in approximately 10% of cases, we can have lung disease before the installation of arthritis. But I have never seen such a case, so for me it was interesting at that time, and we also couldn't rule out infection. So we referred the patient to high-resolution CT. This was done in 2016, and I would like to ask Professor Prosh if he can comment the aspect of high-resolution CT.
Yeah, what you see here are in the left upper image. Oh, the image is gone. I don't see it anymore.
Okay. Okay.
No problem. It's better to see images. It helps. Here in the left upper image, you see this changes already in the anterior upper lobe, which is already suggestive of a connective tissue disease, not approved, but suggestive. And you see analog findings, more reticular abnormalities in the lower lobes. I don't see them anymore.
I haven't touched any. Sorry.
No problem. And it's nicely seen here on the coronals that there are these reticular abnormalities in both lower lobes. The thing is, the bases look like probably UIP. Here in the anterior part, you see this consolidation. So this is either a separate process or points towards organizing pneumonia as a component.
Okay, thank you very much. We also consider it together with our radiologists that it is very likely interstitial lung disease associated rheumatoid arthritis and with this probable UIP pattern. But as you very nicely explain us why we cannot say precisely and to be 100% or 90% confident that this is really UIP. What other question? In part, you answered already to our question, but are there any other possible differential diagnoses considering this particular clinical presentation, a young female, very young female, but the fact that the arthritis was concomitant with the ILD, are there other possible differential diagnoses that we should have assessed?
In the upper lobe, this hints towards organizing pneumonia, which is seen in the context also of connective tissue diseases, but then also in the context of a hypersensitivity pneumonia. So I would not exclude that. That would also be in my differential diagnosis. So either in the context of a connective tissue disease or in the context of a hypersensitivity pneumonia.
Okay, so thank you very much. You already said that we cannot say exactly if it's inflammation versus fibrosis. I understood, and thank you very much for this information, because we are really at loss sometimes to understand. Anyway, our radiologists, for example, say that some of these modifications were inflammatory, and that's why you will see later on that we started with cyclophosphamide for this problem. At that time, that was the way we treated this kind of disease. I don't understand very well how can we quantify, we as rheumatologists, if the radiologists do not tell this information, the extent of the affectation. I understood perfectly what you showed us in the scleroderma, but here I'm not very sure how to quantify the extent.
That's a quite complex process, because the lungs are complex three-dimensional structures, not a sphere, and even in a sphere it would be difficult to estimate the extent. What I do is I always look at these side images, we call them sagittals, and I look primarily at the lower lobes. So the lower lobes are the lobes where we see most of lung fibrosis, and the lower lobes make up 50% of the lung volume of each lung, so roughly. And that's what I then do. I estimate how much of the lower lobe is involved to extrapolate then, to sum up to the whole lung. So that's what I do. But it is a cumbersome and difficult process, not just for rheumatologists, but also for radiologists. It's not that easy.
But anyway, in our case, it seems that it was more extensive, the involvement, not very much, not 50% anyway, but more than 20% probably. I'm not very sure, but this was my impression as looking at it.
Yeah, I could agree. Mm-hmm.
Okay, thank you very much. I would also like Dr. Milena Mann, who's a pneumologist, if in this clinical context we will need more investigation tool, because as Professor Prosch said, we don't have the definite diagnosis. We really need to do some differential diagnosis. If other tools are useful in this case, besides CT and spirometry and DLTO.
Hello. Excellent presentation and excellent case, because it put a lot of problems. For diagnosis, sometimes you put some questions here about BAL, for example. Normally, as pulmonologists, don't use BAL when we had diagnostic, CTD ILD, for example, not all the time. If we have acute symptoms, maybe we think the BAL could make a differentiation between infections or maybe HP, as in case of in Professor Prosch cases. It's not sure. We use BAL for diagnosis between different ILD, but not spatial. When we have diagnosis, it's difficult because we could obtain the microbiological samples, for example, not only with BAL. It's an invasive intervention, and sometimes could exacerbate the ILD. Not so frequent as in IPF, but ILD CDT CTD ILD could exacerbate too. That exacerbation could be triggered by infections, viral infection, COVID infections, or other type of infections. BAL, it's important maybe for pneumocystis, and not all the time we perform prophylaxis. We give a lot of immunosuppression. As pulmonologists, we sure don't give enough chemoprophylaxis for pneumocystis, for example. The other investigations for diagnosis, histopathological, it's really not used for normal as basis. It's because it's an invasive intervention too. You ask us about the lung ultrasound. Lung ultrasound, as pulmonologists, don't use very much. It's it's a new tools in acute institutions. For emergency, it's used a lot. I know some study for you, because all the time you use lung ultrasound, and maybe for screening for pulmonary affection could be screened. You could use this. It's easy. It's easy to interpret. It's not difficult. Could be for screening. I'm not sure that for monitor it's enough. About functionary test, don't help us for diagnosis, but help us for monitor, help us for evaluate at start how severe is the ILD. Are a lot, if you go to slides before to discuss, we have a lot of value, but not of them. It's, we don't monitor all. It's important for us, FVC, it's important that represents forced ventilatory capacity. FEV1 or VEMS in Romania, you know, maybe in some institute use VEMS. We use the report from this, the ratio from these two, because we know we had also obstructive disease, and in your situations, you know that a lot of disease had airways involvement, and DLCO. And for the last, it's important to note for diagnosis, if we think to that, that sometimes if we have a disproportional ratio value for FVC and from DLCO, we think, and this ratio is less, is more than 1.5, we could have some pulmonary hypertension. This is important for you, because if I have, for example, FVC 90% and DLCO 45, it's half. It's this ratio, it's 2. And must think and to ask radiologist or cardiologist if we had hypertension, pulmonary hypertension too.
Thank you very much. Actually, we did an ultrasound of the heart and she was okay. But according to this spirometry, we can rule out bronchial asthma. That was her initial diagnosis in the territory, or we can, because from the she had point some dyspnea, but yes, she was... I understand.
From point of view of this test, I couldn't exclude asthma. I can have asthma when I'm in child. I have symptoms. I have other. This is restrictive. I couldn't stop. Maybe it's obese. I could have other diseases.
Okay, thank you very much. I will go further with the case. So anyway, when we look at her possible risk factors, there was a discussion in the morning by Professor Vanessa Smith about the possible risk factor for RA ILD, and I just underlined what was present in our case. Not very much, was just the seropositivity, very high titer of rheumatoid factor, but also an anti-CCP. So we didn't expect RA ILD in this young female, less than 40 years of age, and she has disease activity. It was high, but not very high, and we don't have the duration. However, if we look at the predictor of RA ILD progression, we already have some ideas that this patient will not evolve very well because we already have the, I don't know if greater extent of fibrosis, probably I didn't underline very okay because it was not very sure that fibrosis was so much, or more than 20%, but probably UIP pattern on high-resolution CT was present. And also she has a low baseline, I think I forgot to underline the FBC and DL, so lower than this value on the presentation. And also oxygen saturation, as I remind you, at the 6 minutes walking test was 88%, so quite low. Regarding the treatment, as I said, it was 2016. The awareness about RA-ILD was not much as today, and we didn't have too many information. The radiologist says it was ground glass and inflammation, and we have anyway the dyspnea and the desaturation, and we decided to give cyclophosphamide. We know that cyclophosphamide doesn't work for arthritis, but actually we treated her for 6 months. She was better, and I don't have the initial high-resolution CT because it was what you saw. It was in June, and I don't have the one. What in November? Sorry, I don't want the one in June. But the radiologist said that it was an improvement of the ground glass opacity on the cyclophosphamide. Anyway, the dyspnea was better. The TBC was not declining too much. Probably it was just stable. And the problem was that arthritis was not very well controlled as we expected by cyclophosphamide. And later on, we started methotrexate. Regarding methotrexate, there was a discussion about it that we will not avoid methotrexate just for the fear of hypersensitive pneumonitis, because new data show us that it's not so harmful. And if you don't have a very severe affectation of lung, you can still give methotrexate, but you have to monitor closely. Unfortunately, she didn't respond, the rheumatoid arthritis didn't respond to any of the conventional DMARDs that are put there, methotrexate and even combination. I will not go through all the details, but we tried all conventional DMARDs, even in combination, and intermittent corticosteroids, and the arthritis was not controlled. And what happened also, while we are monitoring this rheumatoid arthritis with conventional DMARDs, she repeatedly has increased ASAT a lot, and we thought that it was a hepatotoxicity because she didn't complain of anything new. When we insist anyway with the history, we find out that she has some mild rheumatoid renal phenomenon, but with normal capillaroscopy. She declared some muscle asthenia, but she couldn't say very precisely because she said, I have anyway musculoskeletal pain all over, and she developed anyway dyspnea and cough at some time, and even we started to see clubbing in evolution. So we go back to the lab, and we also tested the muscle enzymes that we didn't do at the beginning. I don't know how it happened, but it happened, and she didn't complain at the beginning, and we find that she has not very high, but anyway increased muscle enzymes. Electromyography was normal, but still considering this, the presence of this subtle manifestation of CTD, like Raynaud phenomenon, myalgias, CK elevated, we redo the immunological test. And besides rheumatoid factor that was still very high, anti-CCP, anti-nuclear antibody actually we knew from the beginning that was positive, and the pattern it was anti-centromere. However, when we did the panel of antibodies, it was no anti-centromere positive. ELISA was not also positive, and we have the panel of myositis with anti-PL17 positive. So we have new information regarding this. So we consider that the patient fulfilled the criteria for an overlap. Rheumatoid arthritis overlap with an anti-synthetase syndrome, PL7 positive. We know that it was a discussion in the morning mainly on MDF5 positive myositis, and this PL7 myositis also is a special phenotype, and it seems that appears in younger patients, and usually it's much more often associated with UIP than other types of myositis, and also sometimes the progression is worse than in other types of anti-synthetase syndrome. So we consider that we have enough arguments to diagnose the overlap, and we definitely have this fibrosing ILD, probably due to combination of these two autoimmune diseases. Due to this, because the rheumatoid arthritis, as I said, was clearly not controlled by conventional DMARDs, we started biologics. There are very few data regarding how to treat these kind of patients, but but we know that there are some reports of TNF inhibitor that may aggravate the ILD, so usually we refrain to give ILD, to give anti-TNF as a first line in patients with significant ILD, as in her case. However, regarding the tocilizumab and also even rituximab and all other drugs, there are mixed reports. Some said that help, but others says that aggravate the ILD. We started with tocilizumab at the time because we couldn't give rituximab as a first line according to our national guidelines. What happened, you can see in this slide, it was a complete surprise in a way that not even the arthritis responded. It was a clearly primary non-responder even in arthritis, and we have an important decline of the FVC from 53 to 40 under tocilizumab, so we stopped tocilizumab, and the second line was rituximab. With rituximab, we obtained stabilization of the function, the spirometry. And I would like to ask Professor Prost to comment this high-resolution CT that was the last we did in 2022, to comment about the progression and if the diagnosis is more clear, the pattern is more clear now. I don't know if Professor Prost can see the film.
I see it, sorry.
Sorry, probably it was...
I don't see it anymore?
Yeah.
Okay, so you clearly get the impression here that there's a much more extensive disease. It is primarily reticulation. I don't see any clear honeycombing. So you can call this a probable UIP, if you will, but it does not make, it does not fulfill all the criteria of a UIP. So probably UIP would be a good.
So it still remain, but more extensive fibrosis.
Yeah, exactly.
Okay, so I'm probably here because the movies are a little bit too rapid, but here it's more clearly depicted the progression, and I don't know about the quantification. It's probably more than 50%, as you said. Yeah. And it's clearly a progression regarding the fibrosis. We already see some, I see here, for example, some traction bronchiectasis. What it's exactly. Striking, the fact that it's also on the upper lobe, which is not so typical. Do you think that that's the reason?
No? That's quite, in rheumatoid arthritis, it's quite a common finding. Okay. In fact, it's called the anterior upper lobe sign. If you see an involvement of the lower lobes, posterior lower lobes and the anterior upper lobe, that's in fact very characteristic for connective tissue diseases. It is seen in IPF as well, but much more common in connective tissue diseases.
Okay, thank you very much. So we can say definitely that this patient has a fibrosing ILD with a phenotype that is progressive. So for example, here it's clear that the progression was quite impressive, but there are some others. So from year to year, because we did too many high-resolution CT in this case, the progression was mild, especially before 2018. How can we say in these kind of questions, in the first years where we're not the clear progression, what is clinically important if the patient has a stable respiratory symptom at the time? So not after 2018, so 2017 it was more clear the progression, but if we have milder cases, are there any elements that say that is clinically important if you don't have spirometry or symptoms? On
on imaging or the problem is that this is not defined in what is clinically important is not defined in the guidelines. Okay. So we are left over with the visual estimation. We know that even minor changes in a minor increase, like by 3 to 5% increase as measured by using software.
Okay.
Is a sign of clinical progression and a bad outcome, but to estimate it's visually it's really difficult. This low degree of progression. So this is where we are in the subjective world still.
So we have to combine always with clinical and functional data to say it's a progressive phenotype. And regarding the fact that we did so often high-resolution CT, because at that time this is the way we did. Probably today I will not do so often. Do you recommend the frequency, or do you think we have to repeat this high-resolution CT or other way to monitoring, not with high-resolution CT?
Yeah, that's again an important question and not really solved in the guidelines. I think one thing rheumatologists are more afraid of than pulmonologists is radiation dose. But you have to know that modern CT scanners are able to scan patients with a very low radiation dose. Okay. So in IPF, we perform the follow-ups in yearly intervals. In our center, we perform that also for scleroderma. For rheumatoid arthritis, it's not so easy because there would be too many patients to scan. So it's advisable, I think, at least to do that in patients who are at risk for progression.
Okay, thank you very much. Regarding the evolution of the spirometry, here I put all the spirometries almost every year. The idea is that we see definitely this decline that it was very significant in her case, and also 6 minutes walking test was altered. And I would like to ask Milena again how often we should read, because we did only one per year. I don't know if it's enough. And I'm not sure about the accuracy and reliability of doing sometimes I'm not very sure that it was okay done, or how can we be sure as rheumatologists? That's why we tend to do more high-resolution CT, because we have a more objective, in my feeling, way of monitoring.
Okay, when we have some lesion on HRCT, we must monitor. Maybe patient didn't have symptoms. It is possible. The absence of symptoms could be because the patients have self-limitations of their activity. It's a decondition, and patient remained home, don't move too much. Normal, the monitoring of ILD we perform with functional test. It's important. We have some variability of the test. This is why we recommend to perform to the same device at the same time without, I don't know, close, very short or something that could disturb the patients. But normally every 4 months we must to verify this, because it's important. Sometimes patients didn't feel dyspnea, but we could see more than 10% of VVC or more than 15%, even if the HRCT are normal, are without progressions, we could diagnose progression with 10% of VVC and 15% of the LCO, or 5% of the pulmonary function test with symptoms.
Thank you very much. You already gave me one of the answers regarding the cutoff threshold for initiating antifibrotic therapy with nintedanib.
I want to add something important. In the last 2 years, it's not necessary to perform if I don't have, but the progression, if I have the VVC, I see to your case, because your VVC, it's stable in the last 2 years. This is a problem for us.
But fortunately we have more criteria, not only the spirometry. So if we have, for example, the clear extension on the high-resolution CT, also the symptoms and the desaturation and the subjective measure like Medical Research Council scale of dyspnea, we still have the criteria for to initiating nintedanib. So this was clearly a patient that needed probably even before, but we didn't have available in Romania the antifibrotic treatment, and she was started in 2022 with antifibrotic in combination with rituximab and leflunomide. We didn't try mycophenolate, which you saw in the morning that it is considered today as the main drug, but at the time the information was not that. And also in Romania it's quite difficult to obtain mycophenolate mofetil because the patient has to pay. We have 1 year of treatment with nintedanib. The patient is stable. Anyway, she's okay with rituximab with her arthritis. So we have just the stabilization of the symptoms and the spirometry and the LCO, which it's fine. In the first 6 months, she tolerated very well the treatment, but recently she has some diarrhea, but we gave her measure to combat this symptom adverse event, and she continues. She really needs this medication, so we will not stop if possible. We try to tackle down the symptoms, adverse events, otherwise not to stop. About this, I will finish with these learning points, if you want. I have learned from this interesting case is the fact that RA ILD can be before the apparition of the arthritis. So this is a little bit tricky and it's a little bit rare, but still it's possible. And also that the patient may have multiple immune disease, so that a patient may have overlaps of disease. Probably a good idea if you have especially some other features that are not belonging to rheumatoid arthritis classically, even if they are subtles, or if you have antinuclear antibodies positive, like in her case from the beginning, to test from the beginning the panel of myositis and the antinuclear antibody, the extended panel. In all patients, as Professor Vanessa Smith told us in the morning, we have to have this habit of identifying patient-level risk factors for the development of ILD, but also risk factor for progression if the patient is already diagnosed with RA-ILD. And all these cases that we have presented together today show us clearly that high-resolution CT is central to the diagnosis, but not only to diagnosis, it's a very important tool in prognosis and monitoring and in any important clinical decision regarding the ILD related to connective tissue diseases. The treatment, as you saw here and the discussion in the morning, it's still challenging for rheumatologists and there are not enough data to be certain what to use. We need also experience and new data, but many patients will need the combination of immunosuppressor with antifibrotic. And as repeatedly was said by experts and accentuated by Professor Prosch, also the fact that a multidisciplinary team, it's mandatory. And thank you. And in the last 30 minutes, I will invite my colleague Iulia to present you another of our cases and to discuss. But probably before some questions regarding this case, we still have 1 minute if Doamna Doctor. Thank you.
You before, I'm very practical. I'm not an angel. Today I am the devil. And so I ask you, if your patient will have diarrhea, severe diarrhea, what would you do? Yeah, because it can, so it's such a beautiful case and you manage it so well. So again, I congratulate you. Yeah. And that's why I'm very interested because
so she has moderate diarrhea
and
it impacts the quality of her life. And initially we reduced the dose, but Dr. Milena Maz said it's not okay for the type of, and she tried again. And now we give her symptomatic, and she said that she managed.
Okay, and if not, if you can't give.
I don't think that we have solution. I have other patients that renounce, but I think it's a pity. I don't know, probably Milena will comment this.
Well, I have a question. Sorry. Let's presume that the patient can buy treatment. Would you give pirfenidone to this patient? Now, in my mind. Yes.
Yes.
Let's presume.
Yes. We don't have enough study to sustain this. From my experience from IPF, of course, we could use, but we don't have less side effects than nintedamine. They had other side effects, pirfenidone. From connective tissue disease, we don't have study. We have some study about undifferential ILD. This is why I couldn't recommend you but sometimes the symptoms could be managed. Should be managed, and sometimes after 6 months or 4 months, the symptoms decrease. The diarrhea didn't remain so important.
Thank you. And for my friend and for my colleague, can you try? No. You are my colleague, but unfortunately, you are not my friend. I hope you'll be. So, would you try? So, did you ever try the combination rituximab and cyclophosphamide?
No, I think it's a bit too much.
Okay. Thank you. Thank you again and congratulations.
Thank you. Iulia, please.
Thank you, and thank you, Professor Prosch, for being with us today. I'd like to continue with the case of a 51-year-old male patient, a former smoker with no particular occupational exposure and no significant comorbid disease. Also, the patient didn't receive any current treatments at the time when we first saw him in September 2022. In September, he was referred to our department with history and physical examination suggestive of dermatomyositis. As you can see in the pictures, he had a heliotrope rash, also facial erythema. He complained of mild myalgias and proximal muscle weakness, especially in the shoulder girdle. He also described dysphagia and dry cough. And what was interesting was that he had fever, quotidian fever, for the last 3 weeks. Besides the heliotrope rash, you can see that the patient also had the other typical skin manifestations of dermatomyositis, such as the shoal and V sign, Gottron papules and Gottron sign, mechanic hands, and also synovitis in his right fourth proximal interphalangeal joint and bilateral wrists. The labs showed elevated transaminases and mild elevation also in the muscle enzymes, CK and lactate dehydrogenase. Also strikingly was the fact that the patient had hyperferritinemia, and this combined with his history of fever actually worried us a little, and we followed up the patient because we feared he might develop macrophage activating syndrome. Fortunately, he did not. Immunology was positive for anti-nuclear antibodies in a low titer with a fine speckled pattern in immunofluorescence. And the extended myositis antibody panel showed positive anti-NDA5 and anti-Rho52 antibodies. We had some changes in the electromyography compatible with myopathy, especially in the biceps. And the initial screening for malignancy was negative. So we concluded that the patient had MDA5 dermatomyositis, and given the known association between ILD and MDA5 dermatomyositis, we performed an HRCT. And here is the initial HRCT, and I remind again that the patient was a former smoker, but there aren't any abnormalities suggestive of interstitial lung disease. We decided to treat the patient with high doses of glucocorticoids in association with azathioprine. And in October 2022, the patient came back with a history of progressive dyspnea over the past week with cough and low-grade fever. But just auscultation was normal. The labs showed an inflammatory syndrome. He also had lymphopenia, and the muscle enzymes were normal. So, of course, our first thought was that the patient most probably has an infection because he's quite heavily immunosuppressed. But the PCR for SARS-CoV-2 and also the blood cultures came negative. The sputum culture came positive for Klebsiella pneumonia, but the titer wasn't very high, so it could have been just a contamination. Our second hypothesis was that this patient actually developed acute or rapidly progressive ILD. So the PFTs showed a FVC of 86, which is normal, but we can't compare with previous spirometry, and a decline in the LCO to 58%. And before I show you the images on HRCT, I'd like to tell you that in just a couple of days, the oxygen saturation dropped from 92% at rest to 86, 87% on low nasal cannula. And now I would kindly ask Professor Prash to comment on this HRCT.
I don't see the pictures, I just see Cluj here on my screen.
It should be a video.
No. Don't see it. Did you stop sharing or? Here, now I see it.
Let me go back and start again. Sorry.
No problem.
It is.
What I see here, if I stop here, I see lots of ground glass, which is primarily centrilobular. So centrilobular ground glass nodules. The right upper lobe appears to be more involved than the left upper lobe. I see here the basis already of the apical lower lobes. If we go down now a little bit more.
Sorry.
So lots of centrilobular ground glass nodules confluent to ground glass, more diffuse ground glass, with an upper lobe predominance, if you will, but apparently also the lower lobes involved here is more ground glass. So if I see that the differential diagnosis, if I stay on the acute setting, because the patient is presenting with acute symptoms, would start with infection, then one must not forget hypersensitivity pneumonia may also present with acute symptoms. And then vasculitis would be on my differential diagnosis, as well as this also may start with centrilobular ground glass nodules and ground glass. So this would be my main differentials in such a setting, starting with infection and then with the lower probabilities as mentioned.
Thank you. You have already answered my question. This is what I wanted to ask you, if we can differentiate or make a differential diagnosis between rapidly progressive ILD and a potential infectious, just looking at the HRCT images. But we can't. I have a question for for Dr. Mann as well. Is bronchoscopy useful in this situation, and when is the right moment to ask for it?
I'm not sure we could perform this. Probably if patient was in emergency room or maybe in TI, anesthesia therapy intensive. BAL could help us to predict the response at the treatment. If I have lymphocytosis, probably the response at the treatment, high immunosuppression, could be better. If I have more neutrophil, probably is not, the results is not so good. The diagnosis is only for exclusion the infection. This is for what we could use now in this moment.
Thank you. So we consider that the patient most probably has rapidly progressive ILD associated with anti-NDA5 antibodies, and this is because the procalcitonin was negative. The CRP actually normalized, and we didn't find anything in our infectious workup to suggest clearly a lung infection. So we stopped azathioprine. We gave an extended spectrum antibiotic just in case, and we started IV methylprednisolone and cyclosporin. Initially, we had a slight improvement in oxygen saturation, which raised to 91–92%. Again, I remind you that inflammation, we didn't have any inflammation, and again, the procalcitonin was negative, no leukocytosis, but still the ferritin was quite high. So we thought we should be a bit more aggressive, because this is what we should do, and this is how patients with rapidly progressive ILD are usually treated. And we added cyclophosphamide 1,000 milligrams IV. Unfortunately, the clinical state of the patient deteriorated, and he developed worsening dyspnea. The oxygen saturation dropped to 88% on low-flow nasal cannula, and he started to have fever and chills. So we transferred the patient to the ICU. In the ICU, our colleagues continued the infectious workup, and they repeated the blood, urine, and sputum cultures, and they all came negative. They also perform a sputum smear microscopy and culture for the identification of Mycobacterium tuberculosis, again negative. The galactomannan antigen for the Aspergillus infection was negative, and also the antibodies for Coxiella burnetii were negative. The surprise was that the PCR for Pneumocystis jirovecii came positive. And before we had this result, we performed another HRCT. I will show you the images just now. So after we had the confirmation of PCP of pneumocystis pneumonia, we stopped cyclosporin, we gave the patient 3-metropyl sulfamethoxazole, we continued with dexamethasone and added meropenem. And this is the HRCT that our colleagues in the ICU department performed before having the confirmation for PCP. And again, I will ask Professor Prosh to comment on the images.
Yeah, now it's more ground glass than nodules, which would fit quite well to PCP. The nodular pattern we saw before is rather atypical for pneumocystis cerevisiae pneumonia, but diffuse ground glass, as you see here, this small screen here, would fit quite well with PCP, pneumocystis cerevisiae pneumonia.
Okay, thank you. So we don't have a very specific HRCT pattern, as you know. No. And also I wanted to ask you if you consider if this second HRCT was actually necessary, if it gave us any more information about the case.
It's always, in hindsight, it's always 2020. So if you, I think in an intensive care unit, we're very liberal with follow-up CT scans, because sometimes you see something which then changes your diagnosis or adds something to it. You have to weigh the risk of transport against the potential benefits, but I think it makes sense. Just radiographs are not revealing in that case.
Thank you. So we knew for sure that the patient has had PCP, but we couldn't exclude also a rapidly progressive ILD that was triggered actually by infection. And his clinical state was deteriorating even after adding the treatment for pneumocystis pneumonia. So we decided to add a rescue therapy with intravenous immunoglobulins. These are also safe from the perspective of infection. And we gave the patient 0.4 grams per kilogram per day for 5 consecutive days. And fortunately, everything went well. He was discharged from the ICU department and from our department, and he came back in January 2023 for follow-up. He had no dyspnea, only some intermittent cough, slight proximal muscle weakness, no new skin lesions, and the chest auscultation was again normal. We repeated the PFTs, and the FVC declined to 75% and also the DLCO to 46%, but the oxygen saturation at rest was 95%. At that time, the patient was treated with methylprednisolone 20 milligrams per day, cyclosporin 150 milligrams per day, and of course secondary prophylaxis for pneumocystis pneumonia with 3-metropyl sulfamethoxazole 1 tablet per day. And we have another HRCT from January. And on this HRCT, you can see that there is a resolution of the ground glass opacities, but there are still some articulations in the upper lobes that involve about 30% of the HRCT, or the lung surface. So our radiologists recommended to repeat again the HRCT 3 months afterwards to see how the interstitial changes evolve. And that's why in April 2023, we admitted the patient again to our department. He was doing well. Again, no dyspnea, no muscle weakness, no dysphagia or skin lesions. But now he was on prednisone, 5 milligrams per day, and we decreased the dose of cyclosporin to 75 milligrams per day. And the reason for this was that in the previous weeks and months, he had an increase in his creatinine, and we had to lower the dose of cyclosporin. And here is the HRCT from April. Professor Prosh, could you please tell us a few things about the images?
Sure. So what we see here is these reticular abnormalities with dilated bronchiectasis in the upper lobes are slightly decreasing, indicating that this is probably now a fibrotic state there, for fibrotic residuum of that infection, which you sometimes see after infection. But if you go now to the right lower lobe, if you go back, you see this mass here. It's this round mass. If you would see that for the first time, go down. Stop. You see that for the first time, I would be concerned that this is lung cancer, but given this short interval, this is lung cancer is highly unlikely. So we have to go to the differentials. And if you see a rounded lesion like this in a patient who is immunosuppressed, a fungal infection would be in my differential diagnosis. In a patient who I don't know, also vasculitis is in my differential diagnosis. And then you must not forget that also organizing pneumonia may present with masses. So organizing pneumonia had many phases, but this would be something we see from time to time. So this would be my differentials.
Thank you. So we sent the patient to the pneumologist, and they performed a bronchoscopy with bronchoalveolar lavage, and there were no signs of infection, and the cytology was normal. Of course, we couldn't exclude malignancy only on cytology, but given the history of the patient and the fact that within 1 or 2 weeks after he presented to the pneumology department, he developed worsening skin. He had new rashes. Again, he presented with heliotrope rash, this intensive erythema on his anterior chest, and Gottron signs, but considered that most probably what we saw in the lung was actually organizing pneumonia, and the patient was having a flare of disease with pulmonary and skin manifestations. So again, we started the patient on high doses of methylprednisolone, and this time we added mycophenolate mofetil. He was seen in June by our pneumologist, and they performed another HRCT that saw an almost complete resolution of the lung nodule. And the last time I saw him was in September in 2023, when he had no pulmonary symptoms, no muscle involvement. There was also resolution of the skin lesions. And now the current treatment of the patient is mycophenolate mofetil, 3 grams per day, hydroxychloroquine, 400 milligrams per day, and methylprednisolone, 12 milligrams per day. So there are a few things that, or a few messages that I have for you. Don't forget that anti-MDA5 antibodies are associated with ILD, and there is an important proportion of patients who actually can develop this rapidly progressive phenotype. And if they do, the mortality rate is very high, around 40 to 50%. There are some clinical signs that should alert the clinicians, such as fever, rapidly progressive dyspnea and desaturation, a flaring, or new respiratory symptoms during immunosuppressive therapy. These are actually quite non-specific symptoms, and this could only mean an infection. That's why we cannot make the diagnosis of rapidly progressive ILD before we exclude infection or drug toxicity, and the best way to do this is to perform a bronchoscopy and bronchoalveolar lavage. There are some risk factors for rapidly progressive ILD in MDA5 dermatomyositis, such as the coexistence of anti-Rho52 antibodies. Patients with shorter disease duration are at higher risk as well. Fever, lymphopenia, high lactate dehydrogenase, and hyperferritinemia are all considered risk factors. And the last idea would be that in rapidly progressive ILD, we have to be quite aggressive with the immunosuppression. And most recommendations state that we should give double or even triple immunosuppression with high-dose glucocorticoids, calcineurin inhibitors, and cyclophosphamide. Thank you for your attention.